What if you were told that you resided in a city that had the highest disparity, the greatest difference in breast cancer mortality between black women and white women? What if that was your city? Would you be enlightened to tell your neighbor, your friend, your sister, your coworker to go and have her annual mammogram? Well, that was my city, Memphis, Tennessee. Approximately a decade ago, research was done that looked at the 50 largest cities in the United States. It looked at the disparity in death rates between black women and white women as it related to breast cancer. And you know what? Memphis was number one. Well, that didn't sit well here in Memphis. We did not appreciate that statistic. And hence the formation of the Memphis Breast Cancer Consortium. A number of entities, a number of institutions banded together to change that statistic. And Memphis is no longer number one. Now maybe 7. Still room for improvement, but understand that improvement has already happened, and improvement will continue. And unfortunately, this local improvement that is seen is not noted nationally. So I thank the Memphis Breast Cancer Consortium for their grassroots efforts. And I thank them for this opportunity to share some time with you today talking about breast cancer. My name is Sonia Benn, and I am a breast medical oncologist with the West Cancer Center and Research Institute. Let's discuss a few statistics. It's estimated that this year, over 275,000 women will be diagnosed with breast cancer. Unfortunately, over 42,000 of these women will succumb to the disease. 1 in 8 women is likely to develop breast cancer in her lifetime. That's approximately a 13% lifetime risk. Breast cancer is the second leading cause of cancer death in the United States, only second to lung cancer. But I'm also happy to tell you that there are approximately 3.5 million breast cancer survivors. And we can take this time, this month, to honor them and salute them. But it is important that one thing you remember is that early detection is key. The earliest that you can diagnose breast cancer, the better your chances are of cure and survival. While the incidence of breast cancer is slightly increasing, approximately 0.3% per year, the death rate, mostly in postmenopausal women, is actually declining. We don't yet see that significant decline in the younger population, the population less than 50 years of age. I always like to dispel a few myths, so let's spend a few moments doing that. Myth number 1, breast cancer is preventable. Not entirely so. Even though there are certain drugs that can be given to high-risk women to decrease their risk of developing breast cancer is not entirely preventable. How about breast cancer implants increase the risk of breast cancer? Also not true. There's not sufficient evidence to support that saline and silicone breast implants increase the risk of breast cancer. How about having a family history of breast cancer is the most likely reason to have breast cancer? Do you know that the majority of women diagnosed with breast cancer actually do not have a family history of breast cancer? Inherited breast cancers only account for about 5 to 10% of breast cancers. So that actually means that 90% or more of patients do not have a family member with breast cancer. I like this one. Antiperspirants and deodorants increase the risk of breast cancer. We don't have the data supporting that. There's actually some studies done that really didn't show that that's the case. And then there's the more recent suggestion that sugar increases the growth of breast cancer. That's also not supported. Even though we know that ultimately having the appropriate diet can decrease the risk of any cancers, there's really not a link between sugar and breast cancer growth. There's also not sufficient evidence to show that hair dyes and relaxers increase the risk of breast cancer. So now that we have dispelled those myths, let's put out a few facts. Being female, increased risk of breast cancer. Age, actually, is one of the most significant factors. The older you get, the more likely you are to have breast cancer, or pretty much any cancer. Being of a certain Jewish descent increases the risk of breast cancer. Also, obesity increases the risk of breast cancer. This is mostly seen in postmenopausal women. That's because estrogen tends to hang out in the abdominal fat, in fat cells, and there's a link with estrogen and increased breast cancer. Did you know that drinking 2 to 3 alcoholic beverages a day can increase breast cancer by 20 to 30%? And also we know of the inherited genes, the breast cancer genes, BRCA1 and 2, PALB2, CHEK2. These also increase the risk of breast cancer. But let me let you know that exercise, cardiovascular exercise, walking, vigorous exercise, can decrease breast cancer by 10 to 20%. So what are the guidelines? If you go on the internet, you'll see different guidelines from different sources. For instance, if you look at the U.S. Preventive Services Task Force, you will see a recommendation of having mammograms every 2 years, starting at the age of 50 and going through the age of 74. Let me simplify this for you. I support the American Cancer Society guidelines that recommend having yearly mammograms starting at the age of 40 and continuing on every year, annually, until a woman is really no longer able to go for mammograms or receive appropriate help. Those are the guidelines we really support, starting at the age of 40 and every year. Of course, this is for the average risk woman. And so for higher risk women, those who have strong family histories or even the gene, or they've had an abnormal mammogram in the past, those recommendations actually may change. They may actually be recommended to have mammograms or MRIs of the breast starting at the age of 30. So what do you look for? What are some of the signs? What are some of the symptoms? First of all, for you to recognize these, you have to know what your breasts look like. It's okay. Look at your breasts, examine your breasts. Is there a new lump or a bump? Do you notice swelling in the breast? These aren't normal. Is there pulling, or what we refer to as retraction, in a location in the breast or the nipple? Is the nipple scaly? There may be pain. There may actually be no pain. Is there a nipple discharge that's not milky? Is it bloody? It's not good. Do you notice redness of the breast? Or sometimes you'll even see swollen glands or lymph nodes, not necessarily within the breast itself, but under the armpit, what we call the axilla. Those are concerning. So if that's the case, you should seek care. Go to your doctor and get the appropriate referral for imaging, mammogram, ultrasound. once you go there, once you have something that you have seen to be abnormal, they would typically recommend a diagnostic mammogram. So the screening mammogram is a mammogram that we generally would do every year if there was nothing concerning. Diagnostic mammogram takes several more views and pictures. And if something is concerning, that would then lead to an ultrasound. Understand that an ultrasound is used in addition to a mammogram, generally not in place of a mammogram. If they see something that's still detected, the mammographer will then recommend a biopsy. The biopsy or that tissue is sent to the pathologist who looks under a microscope to first determine, is this truly cancer? If this is cancer, then they will proceed with further testing. And before I end, let me just tell you a few things that we as medical oncologists look for in the testing. So, is this truly cancer, and where's the cancer located? So picture a breast. You have the lobules that house the milk, and then you have these tubes that go to the nipple. Those tubes are called ducts. If the cancer starts within the duct and stays within the duct, it is considered ductal carcinoma in situ within the duct or intraductal carcinoma. These cancers have not broken through the wall, but can with time, so they still need to be removed. The other type would be the more common invasive or infiltrating ductal carcinoma. We see this in more than 80% of breast cancers. Those cancers started within the duct, but they broke through the wall. They invaded or they infiltrated into the breast tissue, hence the name. Once they do that, once they break through the wall, they can go to other parts of the breast or to the lymph nodes or other parts of the body. So we've made the diagnosis, but this is also how we stage the disease. Stage 0, it stayed within the duct. Stage 1 through 3, it broke through the wall, it grew, and it may have gone to the lymph nodes. Stage 4 is reserved for those breast cancers that have gone to other parts of the body, other organs, whether it be the lung, the liver, or the bones. Stage 4 disease is usually not removed with surgery. But in addition to that, the stage, we want to know the grade. The grade is what the pathologist determines based on how far from normal did those cells look to the pathologist under the microscope. That's grade 1 through 3. Have those cells changed a lot? If they're very abnormal appearing, a grade 3. Those are usually more aggressive. Low-grade cancers, or grade 1, really haven't changed very much from the normal appearing cells. And then lastly, we want to look at 3 other things. Very important. This is the roadmap of how I treat breast cancer. Was the cancer feeding off of estrogen? Was the cancer feeding off of progesterone? Understand that postmenopausal women still make estrogen and progesterone. Or did that cancer have a protein that's found in about 20 to 25% of women called HER2? Those are the 3 things. These are important because if it's estrogen or progesterone, there's a pill that could be incorporated into the treatment plan. If it was HER2, we have targeted agents for that protein. What if it didn't have estrogen, progesterone, or HER2? Triple negative breast cancers has none of the 3. And these cancers tend to be more aggressive and tend to be more common in Black women and tend to be more associated with genetic or inherited genes. This is how we make the diagnosis. But understand that whatever those characteristics may be, early detection saves lives. We can talk more about the treatment later. I so thank Memphis Breast Cancer Consortium for this opportunity to spend time with you.